Yeah, so we are live, so I think we can start now. Welcome everyone and very good morning to all dear friends and delegates who have joined us today on this wonderful Sunday morning. Uh, we are here to introduce a great and new venture for all of you, which is Med Virtuals, which is full of ideas for today and tomorrow. As we all know, as we enter into this field of medicine, the first thing which we are doing is MBBS, but then we are introduced to the intricate of these worlds, and a lot of confusion come up because there are a lot of options. We kind of get into a lot of subjects to know, and then we understand that we have to kind of develop ourselves, become a specialist, then subspecialize, then a lot of new options, but there are also a lot of new confusions. So here is Med Virtuals to help you out through this difficult path. And to begin with, we have the best person, maybe in India and also in the world, to guide us through this difficult path. Somebody who has taken the path from resident and now also became the president. So, resident to president, Dr. Deepak Patkar, sir. He is immediate past president of Indian Radiological and Imaging Association. He had his tenure as president in the most difficult years which we had faced, which was 2020, and that difficult year, which was full of difficulties, he transformed all these into opportunities. And that year was called as the best academic year for IRI. So, Sir is there with us. Sir is Director of Medical Services and Head Department of Imaging at Nanavati Super Speciality Hospital, Mumbai. He has nearly 32 years of experience in the field of radiology with key roles in diagnostics, academics, as well as administration. So, he has something to tell us in all these fields to guide us through. He has been instrumental in the clinical team expansion at Nanavati Hospital. So he has ideas of almost all the subspecialty in the field of medicine. He was the past chairman of ICRI, which is the academic wing of IRIA. He's also a key member for the steering committee of indigenous MRI development by IIT Mumbai, Samir project. So also into research, and he has trained over 1,000 students over the past 32 years who are now well established in the field of radiology and even beyond. So not only radiologists, but even people beyond radiology come to get trained under sir for at least some time to understand how can we have a successful practice in future. So without any further ado, I would request Patkar sir to kindly take over.
Thank you, Vidisha, for this kind and exaggerated introduction. Good morning, friends. With great delight, I welcome you all to today's session by MedVirtuals, an initiative by all of us to help out young budding medical students. MedVirtuals is a digital online platform where we shall provide educational material and information covering various topics and subjects of medicine of interest of almost all the subspecialties as the time goes by. The courses are specially designed to help students to prepare for different exams and different patterns that they have to face during their exam times and education. We have also designed a series of carefully curated lectures on different topics in medicine, including case-based reviews, quizzes, and question and answer series. One thing that is common to all the medical students is that they would like to expand their horizons and travel to different countries to broaden their knowledge and sharpen their skills. We Indians are probably hub of providing the biggest brain in the field of medicine, that is doctors and the nurses. Across the world, if you travel, you'll find Indian doctors and nurses in key positions, whether it is Europe, America, or the UAE area. One such popular educational Mecca or destination is the UK. When I went to the UK in 1989, I had absolutely zero knowledge about the application process, choosing the right place and right courses, etc. because specialties like this did not exist. There were nobody to guide us. So I thank Dr. Naveen and Dr. Shashank for taking this initiative because the entire experience for me was really harrowing and cumbersome. There was nobody really to guide. It was all self experimentation. Now, also, I am sure all of you and many more students from our country would like to visit this beautiful place to gain more expertise, look for job, and see how we can crack these exams, but miss the chance to do so because of lack of knowledge about the details, availability of right opportunities, rules and regulations, etc. So our idea today is to solve this jigsaw puzzle as much as possible from our side. And I would encourage all the attendees, and I was told that there are 370 of them, would be happy to answer their questions and be frank and ask questions without any hesitancy. Thankfully, today we have our esteemed panelists, Dr. Shashank Patil, Dr. Naveen Keerthi, and Dr. Ashish Bhushan, who will share and provide important insights and details of the entire process of studying medicine in the UK and finding the job as well. We at MedVirtuals are extremely grateful to them for contributing their valuable time for this session. In future as well, we will be conducting such sessions and we request you to spread the word about MedVirtuals. Without taking much of your time, I would only like to state your limitation is only your imagination. Thank you all.
Thank you, sir, for those kind words. And this is just the beginning. There will be a lot of new webinars and guidance session which will be coming up throughout. So as I said, do spread the word around because all of us have potential, but what lacks is guidance sometimes. So Med Virtuals is going to help both ways. Once they will guide you what to do, and once you are ready with the exam, which exam to take, they will also take you through the difficult path of clearing the exams. So now it's time to welcome our first speaker, Dr. Shashank Patil, sir. Sir hails from Mumbai. He's the alumnus of BIL Nair Hospital, Mumbai, but currently having a successful practice in UK. He's membership in surgery and fellowship in emergency medicine from the relevant Royal Colleges, consultant in emergency medicine at Chelsea and Westminster Hospital, London, director for emergency services, Chelsea and Westminster Hospital, London, also senior clinical lecturer at King's College London and senior clinical lecturer at Queen Mary University London. He has several of affiliations creditable to him. We welcome you, sir, and over to you.
Thank you very much. Um, Before I start, I would like to firstly thank Dr. Deepak Patkar for this bringing and creating this platform to spread awareness and how to get medical students and also his entire team uh, to make this possible. And without further ado, let me just share my screen. So, laughing. Okay, so and thanks Mitusha for giving a brief introduction. It will be pretty challenging, I would say, to really make anyone understand any healthcare system in 10-15 minutes, but I will really give a bit of a framework and synopsis on how UK healthcare works, where does service provision uh, has a role, where is education a role, what are the institutions that are around, and how to go about coming to UK. I mean, the first part is mainly around I do not have any conflict of interest. So what I'm going to talk about is, as I said, it's mainly around institutions, how the hospital system works, how does the education system work, sorry, and what is the training over here. And I think the large part is about my personal experiences on how I went on a journey came to UK in 2004 and the challenges that I faced, and how we have now over last 15, 16 years uh, put systems in place whereby doctors who are accessing or would like to come to UK and train do not have the same hurdles or challenges that we have faced. So, and that's what we will try and do in next 10, 15 minutes. So when I talk about institutions, what you really need to know is uh, what are the key institutions that you'll keep hearing about? It will be either the General Medical Council. It's basically a regulatory body which actually regulates the doctors. Their job is mainly to ensure that doctors have the right skills, have the right qualifications, and they provide with registration whereby doctors are able to practice with that registration in the UK system. So it's more of a regulatory body. The second part itself is in ethos, it's ensuring good medical practice. So they do write rules and regulations which the doctors have to abide to when they are practicing in UK. So any disciplinary procedures, or if you practice something that is beyond the regulations defined by the council, you can face some consequences of it. So it's more of a regulatory role in your life. Recently, apart from holding registration, there's something called as revalidation. So you have to show that every 5 years that you still possess the skills that you need to possess at that specific level, which will allow you to practice in UK. So it's called as license to practice, and they do maintain that. So there are two bits to General Medical Council. And just to keep it very simple, it's a regulatory body, and um, if we have to find an equivalent, it's like a Medical Council of India or what the association that currently is. So that's one separate entity on its own. The next level of institutions are the Royal Colleges. Okay, basically for medicine, it is the Royal College of Physicians. For surgeons, there are all four Royal Colleges that you have. For emergency medicine, that's one. For radiology, and each specialties, most of them have a Royal College. When they get a royal charter, basically they are charitable institute, non-profit organizations, and they work on different principles. What's the role of Royal College in this? So Royal College is responsible for writing up the curriculums for their particular specialty. So their role is not to provide a job. Yes, they may help you with various programs, but that's not their role. The role is to write a curriculum which is very relevant to your current practice, to the innovations that are coming in your field specialty, to make sure when you write a curriculum, what level of experience that you need to achieve, or what level of competencies that you need to build over a period of year by having certain ways of assessments whereby it allows you to practice independently at a consultant level. And that's the role of Royal College. That's what each and every Royal College will do. They sit on various panels. They work closely with the government to define what are the skills that are required at medical levels and incorporate that into curriculum. They work with lots of international organizations, equivalent international organizations, and they learn from them and bring that back to the UK system to ensure that the UK doctors get the right guidance and the right level of education that is relevant to current time. And that's the role of Royal Colleges. They do also conduct exams, which is, we all know, it's membership, fellowship exams, and we've been growing up hearing about them. I mean, I have always heard when I was a medical student, oh, he's an FRCS, an FRCR, he's an FRC, FRCP, FRCEM. So these fellowships, they are, and it's very tricky, but you will be very surprised to hear these are not considered as level 7 education. If you apply for any visa purpose, these are not level 7 education. These are curriculum based, competency oriented, skill based exams which are required to do a clinical practice. And that's very interesting. This is not an equivalent to MD, this is not an equivalent to MCA, it is not an equivalent to a master's program. but it is actually a program whereby it covers the necessary curriculum to practice that specialty in UK. It's very interesting. I'm quite happy to answer questions later on this. Now, just over here, I've put out three bodies. So one is my hospital, NHS England, and the Health Education England. So you got to understand, NHS is very different. NHS is a provider system. When I say provider, it is general practitioner provider, hospital-based providers, and when I say Health Education England, it's like a deanery. Now their rules, it's completely different. Hospital just provides a service. Hospital has got nothing to do with education. That's probably a wrong term. It's not about nothing to do. It's mainly around allowing the doctors to practice the curriculum that has been set by the colleges in a clinical environment. However, the trust, the NHS providers do not hold direct responsibility for your education. It is individual, it is the consultants, it is the tutors who work in those hospitals. It is their responsibility to ensure that the doctors who are in training position get the right education and the right skill. They are not answerable to trust, however, they are answerable to Health Education England, which is also the deanery, what we call as, and to the Royal Colleges to ensure that the curriculum is provided. So it's very, these are separate entities. We are very, very different organizations who have individual greater roles, but they are not networked to each other. So it's very important to understand that. The next bit, we always hear about the NICE guidelines and the NIHR. These are arm length bodies of NHS. Now, NHS, as I don't know how many are aware, it's a fully public sector. 80 or close to 90% of the population in UK receive health care from public sector. They do not have to spend a penny when they access healthcare in United Kingdom. They do pay their taxes, which is where the income comes from. Now, when you are spending money, which is coming out of a public purse, the practices need to be oriented according to the latest evidence. So the question is, who actually vets the evidence? Who says this is the best evidence to have this practice? So because you're spending money, so you need to have not only clinical evidence, but an economic evaluation of the services that you're going to provide. And this service, when you actually fit into the basis of clinical outcomes, financial outcomes, health, long-term health goals, this is done by the institute called as NICE. This is the evidence-based economic evaluation, then tells the government that this practice, this medication, this service, I want a new machine, this is what you will see: a financial benefit, a clinical output benefit, improvement in qualities, and they tell the government or they tell the relevant institution, please incorporate this practice. And that's how it's brought into a clinical practice in UK. So it's an arm length body. NIHR plays the same role. They look at indigenous research, which is carried out um, in the hospital setting, in research institutes, look for latest evidence. The biggest trial, as you know, currently, if I have to use an example, is the Oxford trial, the recovery trial in COVID, the pioneer trial in COVID, and solidarity trial. These are all trials which are run in a government setup, which were designed to actually ensure that whatever evidence is out there is applicable to UK population. So occasionally, when it comes to validation of studies and when other countries use the evidence, we have to ensure the validation is for that relevant country and not just for the country where the trial is performed. So that's the job of NIHR. There are a few more arm length bodies, but these two are very relevant one to clinical practice, and I thought I will make a mention of them. So these are different institutes which work independently, but however feeds into your educational purposes or training purposes. Then these colleges, I have just mentioned a few. I had to put in King's and Queen Mary because of my affiliation to them. But there are many institutes. There's Imperial College. There is, if you go down, then there is Barts Healthcare, and there are lots more in London itself. These are different entities altogether. Their role is to provide education like MBBS. There is nothing like MS in India. It is mainly, sorry, in UK. It is mainly fellowships people will acquire. So biggest role King's Place, Queen Place, Imperial Place is providing MBBS level education. That's a proper qualification. They also do offer courses like master's program, which is called as a level 7 qualification or higher qualifications in any relevant courses over a year, over 2 years, over 3 years. You can then go on to do, if you want certain hospitals, do MDs. MDs in UK, I will talk about that a bit later, but the role of the colleges are very independent to, as you see, other bodies that I have mentioned. So just to bring this whole slide together, there's an array of institutions who work independently and have very different roles to play in UK healthcare. Though they are independent at certain degree, at a very higher level, they come together and there is a spanning of network to give them that individuality. Okay. Okay. So very interesting question I get asked about what is NHS versus what is private healthcare in United Kingdom. Now it's very interesting to see. I have put down few trusts. In London itself, there are 23 acute trusts. Let's not even get into England and let's not get even into the entire UK, which is Scotland, Wales, and Northern Ireland, along with England. And there are hundreds of, if I'm not mistaken, there are about 191 acute trusts in United Kingdom. And the system works very different. And I will try to give you an overview. They are the biggest providers of healthcare. As I said, up to 90% are providers of public health, whereby there is no money spent directly at the point of service delivery by patient. They do pay national insurance, they do pay their taxes, and it's the role of the other bodies that make sure that the care that the patient receives is of extremely high standards and evidence-based. Now, to your right of the screen, I have put these entities. These are some big private providers in United Kingdom, Bupa, Nuffield, AXA. There are private setups. I'm not saying there are no private setups in UK, but when you come as a new doctor, you will you will not work in these hospitals. These are consultant-led service. These are not, there are resident medical officers, but these hospitals have got nothing to do with uh, training opportunities, with delivery of curriculum. There is absolutely no role that or their responsibility to provide the service. This is purely service oriented job if you join them as a resident medical officer. And that's the huge difference. So if you want to really make a career, it's going to be in NHS and it's going to be in trust. That's a very important point over here. Okay. So now a complex diagram, but it's a very relevant diagram. Before we look at the pathway, just to, this is the money, the pink line is money. This is the regulation that we are talking about, license and registration. This is your accountability. So you're using this money, so you're accountable to someone. And then there are local health bodies. So this is NHS structure in England. Top sits the parliament, who is the final accountable. So everybody is accountable to the parliament. And the beneficiaries are patients and public. But you see, they're not looking at beneficiary. If you really see, very interesting arrow in all this thing is that the providers are also accountable to patients and public. So they have to justify about their practice because there's a huge, on each and every council and committee of any clinical work in research in NICE, there's a huge representation of patient or public groups. That's why they don't call themselves as providers to patients and public. They also call them as accountable to patients and public. And that's a very interesting concept. So parliament is what everybody is accountable to, and whoever is in the government actually gives the money to the health secretary, which is the health minister, who then passes the money to the Department of Health, who then gives the money to NHS England, who then passes on the money to the providers to run the service. Providers are the trust. So as you see, this has got nothing to do with education over here. This is about delivering a service. And then these providers are accountable to patients, and then there's various orders of. So as you see, this is just a service delivery model. This has again, I emphasize, got nothing to do with your training and education. It comes and it is regulated by different bodies that I mentioned earlier. Now I've put this. This is just England. This is just England, and I just wanted to say these are the deaneries in England. Right at the top. I mean, here it's Scotland. Here there is Wales further, and up across here is Northern Ireland somewhere. London is just a small part over here. But as you can see, there are so many deaneries, which is the Health Education England Board. They are responsible for ensuring that there are right level of training doctors in a particular specialty in that particular region, and also ensure these doctors at various training grades are getting the relevant curriculum delivered and being supervised by the consultants who are working in that hospital. And this is what I want to show you, that England is a huge, a very small country compared to India, but there are multiple health education boards that are currently working in United Kingdom to ensure the quality of training is of high standard. So if I say, if you are in India and you get a rotation in Sheffield for that matter, for example, if you're a neurosurgeon, you have an excellent neurosurgical center in Sheffield at the Royal Hallamshire. So you are hired by the Yorkshire Deanery. That's how it works. If you are coming to London, as I've said, there are three more deaneries. So I was a trainee of the Northwest London Thames, so it's divided along Thames. So Northwest Thames, Northeast Thames, and South London is how it's. I was a training. My higher training is from Northwest Thames, and my core training is from Bristol region, 7 deaneries. So as I said, and each deaneries work very different. London, you see everything in a small geographical footprint. If you, the south of England always has a little bit of a slightly well-off population, whereas the population demographics in north of England is very different. So health and disease patterns you will see very different in north, not hugely different because it's not such a divided country, but you will see a very different set of population. The talking and everything is very different compared to south of England. Elderly population again is a very huge thing in south of England, whereas middle-aged disease problems are more prevalent in Midlands and Yorkshire region, which is north part. So yes, it makes for a small geographical footprint. You do see everything in London, but you will hardly see any problems related which are more of a south dependent. So it varies. So the bottom line over here is the deaneries are divided all across the UK who are responsible for your training. Now, these are the exams. If I have missed something in all these things, Naveen will definitely add on to it and joins you later. But PLAB, what is a PLAB? PLAB is an exam along with your English language, which you have to. I wouldn't say you have to because now the regulations are different, but you have to pass to get a license with UK or registration with UK. And that's what the role of PLAB is. You do have to have a couple of steps and you have to have an English level exam to get that license with GMC. One of the ways. There are quite other routes which will be addressed in the second lecture. Then, as I said, membership and fellowship examination, MRCS, FRCS, MRChem, FRChem, FRCA, FRCR. All these are Royal colleges, but not considered as a high level qualifications, which is very important to understand. They do give you, these exams are very important if you want to become a consultant in United Kingdom. Now there are various things about service provision. They talk about substantive locum, but I don't want to get into those nitty-gritties at this point. But remember, these are essential part of your training that you have to accomplish to become a consultant, practicing consultant in United Kingdom. Then there are clinical fellowships. A doctor wants to come over here. Say, for example, somebody who was post MD in India has interest in hepatobiliary medicine. And there is a particular service which is more developed in foreign world or the Western world or any developed country or any country where there are very specialized, you see, special set of population, there are new techniques. Then you come as a clinical fellow to that unit. Now, there is no formal qualification, but the advantage over here is that you are one of those specialized people because you have spent 6 months, 1 year, 2 years doing that particular and understanding that particular set of skills. So when you go back to India, or when you come back to India, apart from your MD that you have, which you have got via appearing certain examination, you can claim that amongst all the consultants who are practicing, I have slightly better understanding because I have spent a couple of years understanding with a special fellowship program in particular set of skills in a particular institute, which is considered to be the pioneer institute in the entire world. When we say Pioneer Institute, this is not because of name, it is because of the research paperwork that these people produce to justify the practice that is being practiced all over the world. It is based on the research output, not on basis of number of cases. So it's a very, very important point, which brings me to the next point, which is the research fellowship. When we say research fellowships, you can get an MD, which is a 3 year program, but this has got nothing to do with, for example, it's got nothing to do with your clinical skills. It's got entirely to do with a topic that you pick up and then you keep continuing some evaluation of it, a medical study or a systematic review, and then pres- finish that work over a 3 year period, submit your dissertation or thesis to a supervisor who's affiliated to one of the colleges I showed you earlier, and then you get a formal MD degree in United Kingdom. It is not mandatory for one to have MD or PhD to become a consultant. Consultant is a clinical service provider. It has got again nothing to do with your training to have a consultant job. So that's how you get an MD. If you want to do a PhD, it's a minimal 5 year program, but you are not, this is not about clinical skill. This is about working in one of the specialized institute in one special topic, discovering, rediscovering, finding, putting it in a systematic way, and then acquiring that degree. And that's how you will get an MD and PhD. These are offered by colleges like King's Colleges, Queen's, Imperial. So you have to be university affiliated, and this is deemed to be level 7 or a higher qualification. Okay, so that's the difference between fellowships and MD PhD program and clinical fellowships. It's very important. I've put certain degrees out here, master's degrees, like if you do a year's course in a particular topic, then you get a PG certificate. If you do 2 years, you get a postgraduate diploma. If you do 3 years, you do then get masters. So there are quite such programs. If I have to give you an example, now I am I'm a clinician. Basically, I've got my fellowship and I've practiced. However, I also teach, but I teach on the basis of my experience. But there are certain individuals who actually acquire a master's program in medical education. So they take a formal degree or a master's course whereby they know how to deliver medical education. This is techniques and styles of medication, medical education, how to get work-based assessment, how to do simulation-based medicine. So they actually take a proper teaching a training in how to deliver teaching, and then they have a master's in medical education. These people then go on to become clinical tutors in all colleges or lead of head of departments in King's College or Queen Mary, but you have to have these academic affiliation. And that's just an example I'm trying to give. Master's degrees are again considered to be level 7 qualification. And there are hundreds of courses that you could do to improve yourself as a clinician. I am interested in health informatics, health management, and health finance, and I have I'm somewhere around my master's MBA over here at this point of time. So you can develop at an individual level in these by doing these exams. And I think that probably brings to my last slide, if I'm not mistaken. No, so yeah, I think very important aspect is personal experience. So I'll keep it very simple. I have a couple of minutes over here. I think I'm not running over time, Mitusha. If you could kindly give me a prompt, I'll wait for Mitusha to confirm. Um, so it's very important. So what happened? So I came here in 2004. I was a lost entity. I didn't know what to do because there is no understanding. When I'm talking today with such a clarity, it has taken me a lot of years to understand this process. It was not simple. It took me really years to understand what is this Royal College? What is this business of hospital? What has deanery got to do with all these things? And today it's all clear, but it took me 16 years. And this journey could be cut short if you get the right guidance. You need to know before you come into the country. You need to know because there are lots of people who come to India and offer you jobs and talk about training and so on and so forth. You should have your own understanding in making that decision. So I started off by taking up a non-training post in a hospital under because I needed GMC registration. Those days the regulations were different. So which I took. At that point I realized, hang on, I'm providing service, but nobody's focused on my postgraduate education. I am in same boat as India because the opportunities are exactly you don't know what you're doing. You're just going on giving all entrance examination all over the world. So that was the first step. Couple of years later, I realized that training this is different. So I did a basic surgical training, which was again I didn't know if you do basic surgical training doesn't guarantee you a higher number. Doesn't guarantee you a higher number. You have to have certain degrees at that point of time. And that's I had my MRCS. Again, I realized another thing I have to understand is what are the Royal College regulations now? So I have to go through that process of understanding, and that's when I was very interested in emergency medicine. So I I stopped my basic surgical. No, in fact, I completed basic surgical training. I did not go on to higher specialist training in surgery, and I moved my journey to emergency medicine, and I completed the whole program once again. So that's when I started understanding. Well, now I've got my fellowship. Now I need to be affiliated to a hospital. That's when I took up a job as a consultant as a Chelsea in Westminster. In all these things, when I complete that whole curriculum that has been designed by Royal College, I get a certification of completion of training, which allows me to practice as a substantive. It is a any program is around 7 to 8 years program, right? This is post MBBS. You're putting close to 8 to 9 years to become a consultant in UK, and that CCT certificate or an alternative circuit is important to practice as a substantive. Substantive is a big difference because you can work as ad hoc consultants or local consultants, but to be a substantive, you have to have that CCT certificate, which is offered by GMC in United Kingdom. And then over a period of, because of my interest, I have taken up some roles with NIHR and the Royal College of Emergency Medicine. So journey for me was an experience which I kind of discovered on its way. It did not come. There was no one out there who could explain to us in simple words. But currently, you guys have a big advantage, and as Dr. Parker said earlier, there are I think about 33% of doctors in NHS are from Indian origin or Southeast Asian origin. This kind of data I like to say, but I'm sure I'll be stand corrected by by the next speaker who has access to this kind of data in granular detail. So that would be brilliant. So that was my personal journey, and at an individual level, I don't think so. Anybody should go through that. It should be a lot easier when you come to UK to know the journey, to know the pathway, to know the system, to know the institution before you take up any job, and that's very important. So on that note, I'm going to thank
Yeah.
the lovely team. Thank you very much.
Thank you, sir. So there are questions started coming up in the chat box. So would you like to take a few now or at the end of all the three talks?
No, let's address them now because I think
Okay.
if I
So
address it,
I'll just take them as they have been posted. So one of them have asked, is PLAB equivalent to NEET PG? Also, is it getting replaced by the UK MLA? I think MLE. Yeah.
okay. Okay. Well, I'll try my best to answer, and I mean, if you could dip in there as well. So PLAB, if we consider equivalence, PLAB is a license exam for getting a UK license. So the level of toughness is way less. NEET is about getting a qualification in India. So I think NEET standards are very high, very intense, whereas PLAB is relatively just purely a license acquiring exam, and they don't test your medical knowledge to a level where you have to be a substantive consultant. They purely test. The testing is you have a basic medical knowledge and you have the right communication skills in this country and the basic procedural skills that you can put a cannula properly. It's not about putting a cannula, it is about preparing and then disposing. They make sure that you have those skills before you come to United Kingdom and you do at a certain level. And that's what the role of PLAB is. They make sure you can take a safe history, they make sure you can hand over safely, and that's what PLAB is about. So you can't compare PLAB and NEET over there. I haven't heard of UK Emily. I'm sure there's a bit of a word with it. Must be US Emily, unless I'm unaware. And Naveen will help me there. I haven't heard of UK Emily. So.
Right. So from my point of view, PLAB and NEET are partly similar. I agree with Shashank that in terms of the severity and the seriousness, the exams are quite different. NEET is much more intense. PLAB is relatively easy. PLAB is being replaced by UKMLE. PLAB is just an entry exam. To say that, so in my talk, I will detail further. To register and work in the UK, you need to be registered with GMC. GMC is equivalent to our MCI. Every doctor who wants to practice in India has to be registered with MCI. Same way, every doctor who wants to work, private, public, or NHS, they have to be registered with GMC. And GMC says that you need to meet three essential criteria. One, your English has to be the standard where you communicate with the patients. That is either checked by IELTS or OET. Two, your level of knowledge has to be on par with a final year medical student over here in the UK. And that is what assessed by PLAB exam. So it looks at clinical knowledge a bit, but at the same time, the communication with which you communicate with the patient. So PLAB is that is what it assesses. And the third one is like you have to be from a medical college, which is on the WHO list, what it is called as a WDOMS, World Directory of Medical Services. Anyone who's looking to come to the UK, I would advise ideally do your FRC or MRCS, MRCP, particularly if you have done post-graduation, because that gives you the same level of permission to register with GMC. PLAB is just only an entry exam. It's not a degree. It's not a diploma, which you can put after, like say, I'm Naveen MBBS, MRCP, MRCS. But you can't put Ashish MBBS and PLAB. So it's just an entry requirement. And it is being replaced with UKMLE, which is similar to USMLE, UK Medical License Examination. That's right. I think it's coming in 2022.
Any other question, Mitisha, you want to?
There are many other questions.
I can
The chat box is full of questions now. So, like a few of them, if we club together, it's like people have finished their MD patho. They are interested in taking up job in UK. Then, like similarly, somebody has done a specialty training. So, PG in anesthesia done from Mumbai, and now they got MTI post of clinical fellow for 2 years. After that, what next to become consultant? So few people have just finished their PG trainings in India. They want to like look forward to UK. Few have taken few fellowships also, clinical fellowships, and then they go to UK and become consultants. So if you could guide them.
Sorry. Yeah. So I'll try my best to simplify because each specialty has a different route to get into. Now, how UK advertises job is depending on the requirement in that specialty. So don't think the jobs are made for all specialties because if there is a gap in service in United Kingdom, suddenly you will see that people are out there employing in particular specialty. At one point of time, there was a huge drive to get pediatrician. At one point of time, there's a huge drive to get anesthesiologist. At one point of time, there's a huge drive to get emergency physician. And at times, even general practitioner to provide primary care. So the job opportunities coming on those lines. Now, I heard something around MTI. MTI are 2 year fixed program, which is developed in association with the Royal College, which allows the trust providers to get the regulations in place in an easier way to get these doctors into United Kingdom. Just over 3 years before, it was very difficult, okay, to convert an MTI based training, which is a set 2 year training, into a proper clinical training in United Kingdom. But nowadays things are different. Earlier, they had to return. The big criteria of MTI was you go back to your parent country because you do not want to cause brain drain because it is run by a different. It's an international. It's part of the different treaty that is this is worldwide acknowledged. So nowadays, I'm seeing people are converting MTI training into local training and staying in UK for longer time. So that's about MTI. It applies to all specialty. Um, and for other ones that you asked about anesthesiology, yes, you have to have a job in United Kingdom. Once you are having a job, then you can go through the exam pathway. You can then complete your curriculum, which is designed by all colleges. But which is why when you pick up a job, you have to make sure that person who's employing you has the credibility, i.e., the department has a clinical tutor, has an educational supervisor who will ensure that apart from you doing all the big list for them, also makes sure that that individual gives you time to complete exam, time to complete your regular work-based assessment, submit it to the respective Royal colleges, get your proper accreditation, and hopefully at the end you should have a CCT. There are various routes. You have to have a national training number, which means it is not the duty of the supervisor. It is your individual duty to apply for this national training number, prepare yourself for it, get your CVs in place, get your references in place to get this national training number. It's huge thing. People then go on to do non-training course, which is you do all the same thing, but it is not affiliated or not uh, kind of signed off by the deaneries, which is why you will not become a substantive consultant in UK. That's a completely non-training grade, and then you will become what we call as a SAS doctors or service provider doctors in United Kingdom. Again, it's individual choices. You can be a huge, that will not stop you from becoming a clinical educator because that's a different body. The King's College, the Queen Mary College can hire you because you are masters in particular skills. So you can actually teach on all of that. So that's a different journey you can go on to. It's nothing got to do with just being a consultant. But one is clinician, one is academician, third is research, fourth is whatever regulatory do. You can actually develop all these different roles in UK, and that's the big difference.
Thank you, sir. Looks really helpful. But it's a long way, so I think the sessions which we'll conduct in future, these doubts will be definitely addressed more specifically because because there are a lot of subspecialty and people are at different stages of their journey, and few have finished few parts of exam, few are just starting MBBS, so we can just guide them step by step.
Absolutely.
One of the question is doing MRCP in India, then going to UK or through PLAB, which is better?
Very tricky. I would personally advise if you are able to complete maximum parts that are available in India, if you complete them and come to UK, you have a better opportunity because you also, when you give these exams, you understand how these systems work because they are tuned in a certain way. These exams are not designed out of blue. Actually, on a regular basis, this is what I practice. If you see a OSCE of MRCP or OSCE of MRKM or MRCA, this is what I practice in my clinic. So when I enter a patient, I actually wash my hands. I actually close the curtain. I actually talk to them. I actually ask for chaperone. So this is not an exam that is designed to ad hoc test something. This is what you're expected to do in your day-to-day clinical practice. So if you have passed an exam which is affiliated to a Royal College, you have a better understanding of the system. You will gel with the system much quicker. So my advice at an individual level would be please, if the membership exams, whatever part one, two are available in India, you should complete them because you firstly will have a better opportunity to get a job. Secondly, you already know the system. Thirdly, you know the language of the system, and that's very important. Essential part in UK, apart from your skills, is your communication skills. And without communication skills, you will not survive because you have to work very closely with the nursing team, with the administrative team when you're providing clinical service. So communication and understanding of the system is what the membership exams do.
Thank you, sir. There's a question: is the training CCT and FRCS slash FRCP considered back in India if one wants to practice here in future? And how is it recognized over globe?
Perfect. No, it's a very good question. Um, so CCT is so recognition of any degree is a regulation that is an understanding between United Kingdom and India. So it has to be a understanding between GMC and MCR. Now, not all fellowships are recognized. Okay. Now, again, I don't know whether FRCS as such is recognized by MCR because GMC probably doesn't recognize MS. It works like that. It is a mutual understanding because their curriculums that are designed are specific to that country. It's not because they don't want to recognize each other. It is purely because the MS curriculum and MS training is designed for India. FRCS curriculum, FRCS training is designed for United Kingdom. What allows you to practice in India is your MBBS, and what allows you to practice a certain set of skills is your MSMD. Your MBBS is a basic qualification. FRCS is something like that. You have developed now, and the hospitals that you're going to go and work in are going to say, hang on, this gentleman or this lady has got MBBS, MD, MS, MCH, FRCS. It's very skilled. I can safely say that when this individual sees a patient, he or she is going to deliver a safe patient care. So the decision making, FRCS does not dictate that. What dictates is your skills, what dictates is your understanding, and what allows you to practice is MBS. In UK, to become a substantive consultant, you have to have CCT. There is no way you will become a substantive consultant without CCT. It's no. And to get CCT is not only passing an exam for your kind of information. It is developing whole lot of competencies, leadership modules, adjuvant skills, communication folders, loads of things which you exam is one small but a huge part, but there are lots of competencies that you need to acquire to get a CCT.
Thank you, sir. Another question is: what is the difference between a training and a non-training post in terms of surgical hands-on, comma research and training them as a surgeon?
Again, good question, because surgical training is always very tricky. It was tricky in India, it was tricky in UK as well. So if you are coming as a post MS, you don't want to learn the basic skills because you have the basic surgical skills. What you really want is continue with the practice and learn new skills or additional skills. So training or non-training, these are two different things. What you please don't mix acquiring the skill with training and non-training because you're providing a service in a provider setup. So if you're working with a consultant who is happy to allow you to operate because he or she thinks that this individual can do this service, you can go ahead and do it. Training or non-training is about getting competencies signed off. And as I said, skills is one small set out of all these things. There are loads of other skills. When it comes into training program, these are very structured programs. So year on year, you are kind of given time, you are allowed to go through this process, you are supported to actually go on a journey to get a CCT in United Kingdom. Non-training can be challenging because they are not directly responsible to ensure that that doctor goes from point A to point B where he or she can be substantive consulted. No, you can do alternative called a Caesar, but that is so individually driven, and you need to have a huge support from consultants where you're working. Training is possible because you work in different hospitals. It takes you to a rotation plan. There is a framework. There is a planned framework. So it's a lot easy to become a CCT or acquire a CCT and become a substantive consultant in UK via training pathways. Non-training can be challenging like any other country. So if you ask me at a direct level, I would encourage all the doctors to apply for training program. And this is where it becomes challenging because you are going to compete with UK doctors who are UK trained. And that's where the challenge lies. And the difficult the specialty to get in, the challenging it becomes to get a training program or national training number. That, I'm not saying it's no. You may have to go and practice in the most northern Aberdeen or the Highlands where there's a lot of snow, where nobody wants to go and do number. But yes, you'll have a number. But again, these are the choices you make in life. And that's why I would recommend, strongly recommend to do a training, because even if you go back to India, you will see you'll be a different doctor altogether.
Thank you, sir. So I think two more experts are there with us today, and they'll be covering a lot of these queries in their talks as well. So shall we go ahead with the Dr. Naveen sir's talk and then take a few questions again, the new set of questions. And till then, Shashank sir, you can go through the questions because they are continuously popping up,
I
and
will
they'll
start.
continue to pop up through the lecture session.
Sure.
So shall we go ahead with the Naveen
Please,
sir's session?
please. Thank you.
Thank you once again for addressing all our queries in such details. And this is all relevant, authentic information from directly from the experts who have done everything, struggled through, and they want your journey to be smooth. So definitely, we are thankful to them for taking out time. And we also ask you to keep up sending your queries because we are here to answer them. So now it's time to welcome our next expert speaker, Dr. Naveen Keerthi, who is a multifaceted personality, who is doctor, entrepreneur in UK, part of the NHS England's Clinical Entrepreneur Fellowship Program, team doctor for Silverstone circuit covering their Formula One and Moto GP events, worked with NHS predominantly in the trauma sector, team leader for the 2018 Tex X NHS event. Mini MBA he has completed from Stanford University, co-founder for Doc2 UK, which is doc2uk.com, is an innovative digital recruitment platform for NHS hospitals to recruit high quality doctors directly from the overseas. We welcome you, Naveen sir, and over to you.
Thanks, Mitusha. As Dr. Patkar said, that it is a bit of an elaborated and I think an exaggerated introduction. By the way, you don't really have to refer me, sir. I think usually we do. I remember the very early days when I came and then calling sir everyone. Possibly even my colleagues, actually, I would call them sir because I didn't know actually are they senior, junior to me, but at least they got a job and I didn't have a job. It could be reserved to someone who really deserves it. Like I would call Patkar sir because I know what he has achieved and he's senior. Um, anyways, so what I'll do is like I'll quickly run through about my journey and then share about my experiences over the years being here. So I'll start sharing the screen. If you have any questions or if you cannot see the slides, do message me because once I'm sharing, I'm not really looking at the other videos or expressions. Right, let me know if you cannot see things. I will have to admit that there is a bit of a small conflict because Dr. UK is something I do as a startup, and then as a doctor, I started this. I'll briefly tell about what it does as well. Here is my journey. I graduated from Rajiv Gandhi University in Bangalore, but I studied in Davangere, fall into the same university. And I didn't do any post-graduation in India. This is back in 2002. I worked in Apollo Hospital in Hyderabad for 1.5 years. While doing that, I did my USMLE exams, part 1 and part 2. And I didn't get a job I didn't get the visa to go to US. I have done TOEFL and then I tried to go to US. I didn't get the visa. So I immediately quick turned around and I did my IELTS club and then came to UK. I presume I can relate to this to a lot of the attendees in this conference who are somewhere around this stage, post MBBS or post MS, what to do. And this is, for me, I have a kind of very vivid recollection of how things have turned around during that period, because that kind of remains instantly in your mind. I won't say this is like the hardest or difficult. At the same time, this is the most convenient or easy times of my transition. So since PLAB, I came to UK and I did what it's called as a clinical attachment in the London Northwest NHS Trust. A trust is usually a group of hospitals. So you heard Shashank as well, and then I probably will after that word. An NHS trust essentially means that an NHS, a group of 2 or 3 hospitals together, they form a trust. So I did clinical attachment. So to get a UK experience, because it took me almost 250 applications to get my first interview call. And you need to show, because I didn't do any post-graduation. I just worked in neurosurgery and ICU for 1.5 years at a private hospital. And there was not enough meat on my CV other than I've just done PLAB. And PLAB, as I said, is literally nothing. So that attachment or observership is to improve, enhance my CV. Still, despite that, there is so many doctors at that point in 2004, 2005. It was like super saturation. There was a bottleneck for the positions I'm applying for. Most of my competition is none other than just Indian doctors. So I did the attachment where the consultant who I worked with for almost 2.5, 3 months, she liked me and then she offered me the job. And once you get the UK job, it was easy because now you already had experience. You probably build in connections. You can extend the job where you are in. And that is how I moved through the career. I did work in one of the premier hospitals called Guy's and St. Thomas. And there was an application process called MTAS MMC back in 2006. It was a bit I won't say discriminatory, but then it was like a system they have put in place which favors the local graduates compared to an overseas graduate getting into a training job. A lot of you are asking about it, difference between training, non-training, how to get in. That MTAS MMC system favored the local graduates over overseas graduates to get into training and progress in the training. I mean, progression is the same for anyone who wants to get into the training. I didn't get into that. I got into a level of training where I do what it's called as a CST, core surgical training. I'll tell more about it. I did my MRCS, I did my sports medicine, British Association. I wanted to do an orthopedics as a career. I kind of hit a stumble a bit because again, there was a bottleneck at what we call as an orthopedic trainee to go further. To enhance again my opportunities to become an orthopedic surgeon, I did an MD from UCL. And once I got the opportunity, it was kind of a little bit too late for me. And I chose to stay in London. And now my opportunities were outside London. And I was preferred because my wife works in fintech. And the opportunities are much better here in London than anywhere else. So I wanted to stay in London. I moved into emergency medicine. I started doing trauma. This is a period where I went to US as well. You remember the 2003 times when I did part 1, part 2. I did US clinical skill assessment, and I completed that in the US CSA. And I've seen like an observer, I've seen the system from there for almost 3 to 6 months. And again, getting into orthopedics in US was even more trickier and difficult than in the UK. They say that you have to be either military personnel or like a kind of a very typical white. So I came back to UK and settled down in London in emergency. And this is a period where I've seen the journey of like transition, UK's requirement, how is the recruitment sector is moving around. I was starting to get passionate about like the requirements and then the supply chain. And I did a mini MBA from Stanford University, and I enrolled in an NHS England program called Clinical Entrepreneur. The system supports, if you have an idea, it's unlike like doctor is just a doctor. Here it's different. If you have a new idea, it could be a digital app, it could be a new treatment modules, anything. If you have an idea and it's got some kind of feet on it, and the system encourages, particularly if it is good for NHS, general health for anyone. And that is how actually it started Dr. UK, and it was part of NHS Innovations. So my conflict is Dr. UK essentially it's a recruitment agency, you can say, just like there are a few other private agencies. What we do is we connect doctors from overseas. The journey which I went through and the team actually who formed this, we went through, to the hospitals which need doctors. And we built a digital platform which makes the connection much more easier. I'm not going to talk anything more about Dr. UK. I've told enough because I want to get the conflict out of the way. Whatever I say, it's kind of very unbiased from here on. And you should be able to say it. Right. Very important things. I don't want to have, as you see, around 12 slides. I'm in slide 4. I'll try to spare under the 15 minutes on the rest of the slides and tell you like how exactly the journey has would be for any one of you who envisage or see your future here in the UK. This is a very generic stat. This is from a body called OECD, Organization for Economic and Cooperative Development, usually predominantly a European body. They kind of give the stats about the number of doctors in a country. And they said that UK has 2.7 doctors for every 1,000 people. So we have around 68 million population. That is 6.8 crores in the UK. And for every 1,000 people, there are 2.8 doctors. The recommendation by OECD for any country, you should have minimum 3.2 doctors for every 1,000 people. So UK is struggling compared to particularly their European counterparts. They are a bit less number of doctors. Guess how many doctors we have in India? I know it's okay, one way through. So it's 0.9 actually. But the cities, they have almost 3.7 doctors for every 1,000 people, while in the villages it is 0.7. Which is where this is I'm not making it up, it's from the WHO. So while in the villages where it is kind of required mostly, it is 0.7. So it becomes imminent. Yes, I made the journey. I came over here. Is it really worth picking up doctor from a country which has less number of doctors and move them into a country which has more number of doctors? And so this is a question actually I pondered a lot of the times. Like say, even if we are doing recruitment, does UK should recruit from India or from any other country which has less doctors? But then a constant thought comes around. The world has become a small place. If someone had told me 15 years ago, Naveen, don't go, India needs you, I wanted to come train and I wanted to go back. But somewhere in the process, I kind of very strongly kept telling, no, I'm not, I will be going back. I'm not staying here. India is home to me. And I've realized actually, life is like where you find comfortable with. And the world has become such a small place. I've seen so many people who have come and gone back because they've done well or because they haven't done well. It is where actually you have the people and you have friends and where you make life. And for me, that is what happened in the UK. And then I chose to stay. In India, I think it is kind of a bit of a rat race at some point. I've been through that as well. Your PUC, your NEET exam, your MBBS, rushing through, and then again your race to get into and post-graduation. And then again, after that, getting into obviously marriage, and then getting into a private hospital job or even a government job, and then through for the MCH or a DM. Maybe at a point we can pause and then try UK or any other country, explore it. Actually, that's fine. If somebody goes ahead of you by a year or two, I realized actually I was in that race as well, coming to UK as well. Oh, I didn't get it into US MLEs, and then I have to go to UK. I think that's fine, actually, to take that pause, explore probably UK, US, Canada, New Zealand, any other country, and then see the system for 1 or 2 years. If you like it, you stay, apply for training or non-training or progress in your career. If you don't like it, at least you take up an experience back to India. So don't see, because grass always looks greener. In the next few slides, actually, I will elaborate more about it. UK, it looks like, oh, promising. Oh, it's a Western world. It's a developed country. The healthcare system actually, sometimes it feels so easier in India to work and then progress. Over here, it looks convoluted, complex. But that's fine. 6 months, 1 year, you tried, you looked around, and then you chose not to continue here. That's fine. So I'll move to the next slides. This is directly from GMC. We have a bit of it because of my program. Actually, we had direct connections with the GMC. I spent a whole day learning about the process of how a UK doctor, compared to the times when I applies for registration in GMC and comes to get his registration done. And from them, I got this record. This is historically for the last 30 years, overseas doctors who came and registered in the UK. And you see in 89, usually what I've observed, the trend is like, it kind of forms in a cycle. So in 2002, it's like the cycle is at the peak of it. There were like 12,000 doctors who came in just in 1 year from overseas. Most of them, at least a third of them have come from India, rest from other countries. And GMC registered them. And this is the reason why there was a bottleneck when I went. I went in 2004 end, because there were so many doctors, they filled up all the positions, there are hardly any, and then there are many like me who have come as well in the subsequent 2003-4 years. And that is why the bottleneck for me, 250 applications, as I mentioned earlier. That cycle, as you can see from the trend, is all over again. The reason to show this slide is like whoever is anticipating or thinking about moving to the UK, be aware of this stat. Maybe what is a brilliant opportunity, as now advertised, there is almost a need for around 11 to 12,000 doctors in the UK. But in 2 to 3 years time, it may not necessarily be that open. There could be a bottleneck as to how we faced or I faced back in 2004 and 2005. Anybody who is from this slide anticipating or looking to come, probably a time to make that big gush. If you have done your MRCP part 1 and part 2, work harder in 3 months, 6 months, try to finish your paces, and then if you're looking to come. I'm not encouraging, as I said, it looks greener and it's not really that good. But for an experience you want to come and try, yes, absolutely worth it. This is the journey, again, from that particular slide, the previous slide. This is just the UK, Indian doctors who have come into the UK. UK has always relied on overseas because they got 24 med schools in England. They increased it 3 more in the last 3 years. 6,000 doctors graduate every year. While in India, we have like 65,000 doctors who graduate every year. And they don't have, because there are like almost, I think, 40,000 doctors who are above 55 years age, but then they continue until 65, 67. So, but there is the number of doctors who retire and leave is not really matched by the medical school intake. And that is why a lot of Indian doctors come and then they get opportunities and then they settle in, they progress in their careers. Here is in the year when I came, 3,600 doctors, and 2005, 2000, almost 3,000 doctors, and then they all stopped coming. So over here in 2013, there are just 340, 1/10 of the doctors who came only from India registered with GMC. This is the data directly from there. And the number one reason, because there was a lot of feedback around this period, people could not settle in, the visas were not extended, they could not progress in their careers, they kind of stunted, becoming like a mules in the system. So if in a private hospital you have, I remember in the private sector when I worked, my consultant never wanted me to leave India because I was doing the job for him so well. And then he was UK trained, and one of the aspirations for me, but I was doing the work so brilliantly, so well, seeing the patients, doing the discharge summaries, speaking to the patient. But over here, you kind of end up becoming like that as well. A lot of them have become, and then that is what got fed back, and they stopped coming. But now, as I said, the current shortages is so high, and it just kind of realized from its own mistakes that we cannot actively discriminate, and we shouldn't. And a lot of them actually now that big from that following surge, a lot of clinicians like Shashank have become senior doctors, and then they kind of actively retributed, pushed away any kind of discrimination from overseas doctors. Now, doctors who came to us actually back in just before COVID, almost 20 of them, they got like the visas in 4 working days. 4 working days, it's like almost unheard of a UK visa, a 3-year working visas. GMC registration has become much more simpler. I'll tell about that journey because that is the most important if you're looking for a UK career, things for you to follow. And there has been a gradual increase, as you see, in the number of from India doctors applying or getting GMC registration. 2019 year, I think it's almost 2,000 already. This goes back into like how and why is it worth to come to the UK? I mean, you all know about the Indian system, the public system, and then the government hospitals, and the education system, the training system, and the private hospitals. I'll briefly tell about these 2 systems from the experiences. I don't like US system at all because it's completely private. I don't think there is ever anything government. This is mostly from the perspective of a patient rather than as a doctor who is providing the service. And if you have like, despite my brother is a software engineer, like many South Indians from Hyderabad in the US, he's been there for 20 years now. And despite how much ever you earn, how much ever you save, you probably have a diagnosis of like a cancer or a major road traffic. Almost all your savings are gone. And the amount of the nitty gritties and the paperwork just to stay legally safe, it kind of takes partly the drive away. Yes, you have a lot more earnings compared to as a doctor compared to UK or India. An average doctor, I presume, would earn around 300,000 at least dollars per year. But this is after 5 years of residency. Residency gets you paid probably around $2,000 to $3,000 per month, which is like $70,000 probably per year. But once you finish your residency, it kind of jumps almost up to average, around $250,000 to $300,000. Pretty good salary. You pay a lot of taxes within that as well. You pay a lot of insurance premium as well. Uh, but at the same time, would you be happy? Because you are again driven by a system which kind of makes you do procedures sometimes a bit unnecessary. And then you see the patient suffering through as well. I didn't enjoy it. I could have had pushed and then taken an alternative emergency medicine options and so on. And I didn't get the field of my choice. And then I was not really kind of positively uh, drawn into it. Right. Then comes the NHS or the UK system. 95% of the service provision, 95 in the UK is through NHS. That rest of the 5 is private. So anything to say NHS is completely free. My next door neighbor is a chef in one of the big 5-star hotels. He's from India as well. He's been here for 6 years. One day he was suddenly in a prayer room and he didn't wake up. Instantly, his father-in-law was there, and then he just went in to see, and didn't wake up. And when they did the series of tests, he was severely hypoglycemic. They found an insulinoma in him, and he didn't realize he was living on like an BMs of 40 by the Indian terms, so 1.2, 1.3 over here. He's always been apparently. He didn't even realize that, but that particular day, it so happened. So once he went into the NHS hospital, he's not in permanent residence as well, by the way. He's just on a work visa. NHS did all the tests. He had an MRI and then he had a PET scan. And then they said that the surgeon, upper GI surgeon, need to identify the small tumor within the pancreas. So they paid his flights, paid his 3-star, 4-star hotel in Switzerland. They sent him to Switzerland, the center. He stayed there for 2 days where they put the radioisotope, identified it, and then marked that tumor. And he came back here, the upper GI surgeon did the surgery, and then he's completely free. So his story I'm just telling because that is what NHS service provides, irrespective of the tumor, trauma, anything, your service provision is like absolutely free. You don't have to pay a single penny. And he was being paid as well, kind of a salary, so to run his family expenses because he was not working. But that is what the UK system provides, the NHS provides. So as a patient, it is really good, particularly for elective things, for emergency things. For elective things like a total knee replacement, hip replacement, you have to be on the waiting list for 4 to 6 months. But emergency, it is really good. As a doctor, compared to the US, what we talked about, and Indian salaries, I'm not talking because you are the experts there. Average salary comes to be about 80K. 80K is like around 120,000 US dollars. Is it good, sufficient? Roughly about sufficient, 80 to 90K, I would say. Can go up to 100K once you specialize or gather it around 5 to 6 years of experience. But it's kind of more than sufficient. If you're 2 people, it's very comfortable. And just like the healthcare system, the education system is completely free. These are the 2 predominant costs for anyone, particularly from the Indian diaspora. And that is addressed there as well. So being here in the UK, am I happy? Yes. Is the system very good? The provision and then the guidelines we follow, the nice guidelines as Shashank kind of clearly elaborated about, absolutely yes. Because there is no financial incentive motivation. The hospital is not saying that I'll pay you more bonus if you get more treatments or more patients come into the ICU. No, you do absolutely what is required for the patient, putting everything into the factor, your hospital capacity, what is the best evidence essentially, and what is right for the patient at that point. So in a way that, I get to feel like when I do say in orthopedics and ankle ORF, when I speak to my friends in India, there could be some conflict, and then at least we follow like the current best evidence, and then they do follow as well. They're so advanced now. Sometimes actually the knee techniques actually they are a bit ahead, but only I guess in the premier private institutes. Anyways, next slide tells about a lot of the questions during Shashank's chat about training and non-training. This is a typical training journey for a UK doctor. We do undergrad medical training, say MBBS, and then we do 1 year of internship. This is where it follows. And then we do 3 years of post-graduation, and you're a consultant, right? So once you finish your final MBBS, 4 years if you are smart, 5 years if you take 1 year time out after your internship or during internship you prepare for the need, and 5 years time you can become a consultant. You do MD Obs and Gynae, MS Ortho or general surgery, MS Orthopedics, you're an orthopedic. You can do maybe in a small hospital as a consultant, not necessarily in a big hospital. But over here, the system is different. After you finish your MBBS final year, you do what it's called as a foundation training, 2 years of kind of internship. You get paid. You get paid roughly around £2,000 per month. So that overall around 35 to 40,000 kind of overall salary. And you apply for training at that point. Most foundation 2 trainees during the second year, they decide what career path they want to choose. They put into the context the competition ratios and what is their passion. During this F1 and F2 2 years, they would have rotated at least 6 different specialties, and they would have had the experience and then pick and choose what is their field of interest. Some could just become a general practitioner. Most will choose either what it's called as a core medical training. So am I taking too long? Sorry. Right, I'm going to carry on. I'm assuming actually. Right. So once you finish your foundation 2 training, then you choose your specialty of interest. So if you want to become a medic, if you want to become a surgeon, then you do 2 years of core training as a medic. As a medic, you will rotate through emergency medicine, acute medicine, probably cardiology or gastroenterology for 6 months. So once you finish this 2 years, this is when you do your MRCP. And by the way, you haven't even applied for training yet. You haven't become a registrar even. You're still as a junior doctor, which is kind of an extension of being an house surgeon. And then you applied for what is the ST3 to ST7, which is your proper registrar training. You do your cardiology or gastroenterology, or even actually, if you have chosen in surgical part, you do your MS orthopedics equivalent, doing only orthopedics is from here ST3 to 7. So from the time you graduate to become a consultant here is almost 10 years. So if you say an orthopedic surgeon or a consultant or a general surgeon over here, he has had like 10 years of training, and that covers almost so many specialties, not just MBBS internship and then 3 years of orthopedics. It has covered like general surgery, emergency medicine, pediatrics, obs and gynae, 3 months each, not just our internship of like 2 weeks, 4 weeks. But then you have done minimum 3 weeks in multiple specialties, and orthopedics clearly easily up to 7 to 8 years. And that is the biggest training difference compared to India. And even before you get on to that ST3 level is when you do your MRCP, MRCS, MRChem, and other specialties. There are few specialties where you apply for a run-through post, where after you finish your F1 and F2, you directly jump into ST1 and then do the training probably for 6 years, not necessarily 8 years, like emergency medicine, anesthesia, obs and gynae, radiology, But more surgical or acute specialist medical subspecialties, you have to ideally go through here. When an overseas doctor like us who comes, obviously we don't do this because we are kind of post this. Like when you have done your internship or a house surgeons in India and worked in 1 year, like I did 1 year, 1.5 year Apollo. So I was kind of this F2 level experience. So I applied for CT1, but I kind of repeated F2 job here. And we apply for jobs mostly around at this stage, but not in the training part, in the non-training part. And work here for 1 to 2 years, during which if you have not, or most have completed by then, MRCP, MRCS, MRChem, they apply for ST3. Shashank clearly mentioned multiple times, and I cannot reiterate the importance of applying for an ST3 or training job at this level. So it's a seamless progress for you. It will be a bit compromised salary compared to a non-training job. You get like £10,000 less salary per year. If you're getting here 75, you probably will get here 64. Still, absolutely worth it to get into a training job because it's a seamless progress to become a consultant in 4 to 5 years' time. A lot would not get into a training job and will continue as non-trainees. They can become consultants as well, but it's a lot of individually driven, and that pathway is called the CSER, driven pathway to become a consultant. You probably don't want to waste too much time applying for it and then actively follow the CSER pathway. And quite a few I've seen actually chose because they could not become consultant. They don't like to be the mules in the system here. They go back to India. So there's something you have to understand. Can I give a guarantee like everybody gets? So what is the ratios? Maybe around 30 to 40% chance in getting into there. We don't know who it is. Like it's always individual driven. How many audits you've done, how many publications, how many presentations. These are like one of the key factors to drive and score highly in terms of your applications, and which just whilst in India, we haven't contributed much. So this is the ratios, probably don't spend too much. I'm not going to elaborate more. This is again a stat, like 30 to 50-year-olds, most of the IMG, so international medical graduates, neither from UK nor EU. Now, actually, we are all the same post-Brexit. The light green or the dark green, and then EA and IMGs, we're all the same. Everybody's treated the same. And they constitute of the non-training jobs, almost 73%. So this is where we kind of want to be, it started this in a way that we could give guidance so that you don't end up in that system and then you go into that ST3 or training job. So something to consider actively before you come to the UK. Do you really want to come now that you've seen a bit of a stats and then understood? I probably will be able to share a bit of them as well once I get the most accurate one. These are, I think, 2 years old. But COVID has affected us, so the numbers would be scattered a little bit. But something actively to consider. You probably have done like MS in India or an MD in India, and then you come and start to work at this or at this level, but in a non-training job and don't see yourself progressing and want to continue staying here. Or as I said, come off the rat race, work for 1 to 2 years, understand the system, try to apply. You might not even like it, even if you get it, and then continue as this to earn a bit of salary, understand the world. Going to Paris is like, it takes me 2.5 hours. If I drive 4 hours from London to Paris. So in 1.5 hours, actually, you have a direct English Channel undersea train, which takes you straight there. So you can explore a bit during your time. Something to consider when you make that big decision to go or not. But again, that has to be matched by like opportunity and how much work you're going to invest. Let it be preparing for GMC registration, these exams, and they're not cheap. They're quite expensive. Any Royal College exam would take out at least, I guess, 1,000 to 1,500 pounds, which is like 2 lakhs here, 1.5 lakh. Right, going to the most important crucial things. To come to the UK as a GMC registered doctor, you have to have at least one of these 4. I would never encourage anyone to do this, particularly to come and step into the UK system, because they cost like an MCH is nothing. There are a lot of you might have had come across. They cost around £36,000 per year. What they do is like they get you into a program and then they say that we'll pay you a salary while you work as a doctor at this level. But the need is almost so high. If you do an lab or MRCS, you don't have to pay anyone those £37,000, number one. And number two, the MCH title, what you get is nothing comparable to what the MCH or DM in India is, MD Clinical Medicine or like MD General Medicine in India is. Might as well work hard on your MRCP, MRCS, or any other Royal College exams and directly get a job over here at this level and get paid around £70,000 rather than paying someone £35,000. But that is a part to register with GMC, partly. MTI is a 2-year restricted pathway where after 2 years you will by rule have to go back to your parent country where you came from and then again reapply for a visa if you like it and want to continue. Otherwise, MTI is a scheme, and not all necessarily all hospitals provide that service. I think if you go to the individual Royal College websites, they will detail the list of hospitals who are providing MTI service. But this is the path I chose, still exists, plan. And now a lot of doctors are coming, whoever have done MRCP, MRCS, MRChem, any Royal College exam. For anesthetists, it is ED, AIC, or ED accepted as well. So as I mentioned during the break time, the 3 essential things to come to the UK is like, or to register with GMC. One, your medical school has to be on WDOMS, World Directory of Medical School. 99% of Indian medical schools are on that list. So you will meet the number 1 criteria. Number 2, your English has to be on par with a doctor over here who can effectively communicate. You can, acknowledge that, understand why they put that rule. And because it's an English speaking country, and then your English has to be fluent, that you're communicating well the message to the patient. And that is assessed either by OET grade B. Ashish is going to speak quickly after me. He is the, by the way, regional head for the whole of the Southeast Asia for OET. And or IELTS, one of the two. IELTS, you have to get a banding of a score of 7.5 out of 9. And then 3, one of these 4. These are the 3 criteria: WDOMS, English, and then one of these 3. But this is to assess like your knowledge is on par with the final year, at least of a final year medical student. And the PLAB is being replaced, as someone quite rightly mentioned, UK MLE. I think the next year it probably come. COVID has kind of kicked it out a bit. The 3 there are followed up with a bit of an extension, like getting your certificate of good standing from your local council and references from your consultants who you work with. These are the other things as well. I'm assuming that everybody is safe, right, and practicing to get these. That's where I finished. I think I hope I haven't taken a lot more time than required. And this is what we have done. We kind of, from our journeys, I know the hardships, like coming here, finding your phone contract, opening a bank account, and setting into the system, getting that attachment or progressing in your careers. We have found it a bit hard. And we built in this, like we brought a network provider, so all of our doctors get free kind of a phone for 6 months, and then they get bank accounts and they get the guidance in terms of settling into the system and progressing. Again, nobody can guarantee, and this is what we do. Right. Any questions, put it in the chat and openly for to me and Shashank. And I'm sorry if I've taken a bit longer than needed.
Thank you, sir, for this detailed explanation. I think most of the queries were related to what you talked about and the flowchart approach you took, because that's what the queries were relating to. A lot of questions are coming up, so we can take a few and then go ahead to the next speaker. So you're muted.
Mitisha, I
Yes,
think it might be easier, let Ashish finish it, and
okay.
then possibly we can all take it together.
Sure, no
So,
problem, sir.
because me and Shashank can jump in. At least we know that we are finishing on time, and then I'm
Okay.
happy to say as long as it required. I don't have any time constraint. I don't have any time constraint. So,
Yeah,
but at
yeah.
least for those who wants to finish,
Yeah,
hope
yeah,
it's
sure.
okay.
So we can take first Ashish's session and then we can go ahead. Fine, no issue. So I'll just start my screen share. So after Dr. Naveen's session, now it's time for Ashish Bhushan's session. And he is OET Senior Business Development Manager for South Asia Group and leads on creating awareness about OET and support its growth in the region through various key stakeholders associated with Cambridge English since 2011 and leads the higher education and corporate sector along with various government projects. He has worked on the recognition strategy for Cambridge English exams in the region and has developed an initiative called Campus to work that help higher education institution to connect with employers to enhance their placements. Prior to Cambridge English, he has worked in leading brands like Pearson, NDTV, Monster.com, and Reliance Telecom in domains of technical, marketing, and business development. He's completed the engineering bachelor's from Dr. B.R. Ambedkar University, Agra. We welcome you, sir, and over to you.
Thank you so much. If there's a possibility, I can share my screen. I think you'll have to stop sharing and then I can share. Thanks
Yeah,
a
you
lot.
can share it now. Yeah, yeah, sir.
Right. Just a second. Okay. I hope my sound and video are clear.
Yes, yes.
All right. Thanks a lot. First of all, I would like to say huge thanks to Naveen and other participants attending the program. Thank you so much for inviting me. So my name is Ashish Bhushan, as Mitushi mentioned, and I look after OET business for South Asia region, mostly for India, Maldives, Sri Lanka, Bangladesh, Nepal, and Bhutan. So these are the regions which we cover. As an OET, I'm sure some of you might have heard about the examination. This is largely an examination designed for healthcare professionals. It stands for Occupational English Test. So what I'm going to do is, in the given time slot, probably not more than 15 minutes, I'll try to cover what's and how's of about the examination, and then we'll be happy to take your questions. So very quickly, just to give you a quick background about our vision, we are designed for the healthcare industry. The professionals who would want to work in the healthcare professional through the language communication is what we assess. So our vision is to connect the world to better healthcare, and mission is to set the benchmark for global healthcare communication skills through industry-wide collaboration. That would mean connecting the professionals to the healthcare boards or regulators. What I'm going to cover is largely about these parameters in terms of how the exam is different to other English tests, what is covered in the test, how do we score, and how the candidates are prepared, followed by some testimonials. So let's quickly jump into the examination per se. So the test itself for occupational English test is designed for healthcare professionals, so which has been developed in consultation with subject matter experts. So while you might have heard about language English, general English language test, how we differ is ours is a more healthcare related test. So apart from the language experts who are involved into developing the test, we also have subject matter experts who help us develop the test. The test materials replicate the language skills required to deliver patient safety and quality care. So which means we are not really only assessing your language communication, but also your workplace skills. Although we try to test your communication skills, but while through the journey of preparing for the examination, one would understand what are the kind of topics and practices that are being involved into the industry in the healthcare sector. While all of you are doctors, I'm sure you definitely understand, but since the test itself is designed in a way to help the developed nations or professionals who are working in an English speaking environment, it really helps, and that is something which I'll be covering towards the end of the slides. Third aspect is candidates learn the type of language they need at work. What are the versions or what are the professions that we cover in OET is basically the 12 professions. Some of the most popular ones are definitely medicine and nursing, occupational therapy, pharmacist. So these are some of the 12 professions that we cover. What happens is throughout these 12 professions, although we cover coming to the communication part of it, there are four aspects to it: reading, listening, speaking, and writing. And in reading and listening, for reading listening, all the 12 professions, the context of the examination remains same, while speaking and writing differs. So that is something which I'll cover very soon. How a healthcare specific test differs from a general English test. A quick understanding about writing and speaking. I'm not sure how many of you would have taken an IELTS or any other general English examination, but how OET differs is comparing in terms of a writing examination. Probably in an general English test, you will be asked to write an essay on a general topic, while in our case, in OET, you are asked to write a referral letter or a healthcare letter. So basically, there's a situation given. On the basis of that, you will have to you're asked to write a referral letter. In terms of speaking, while in both general English and OET, it's a more of a role play or a conversation kind of a scenario. In OET, we do a role play kind of a task wherein you'll be given a situation, and as per your profession that you would have chosen, you'll be asked to perform the role. So there's a scenario given, there's an interlocutor who will be sitting opposite to you, and that interlocutor will help to facilitate the conversation, and you basically will have to perform the role of a doctor or the profession that you're playing there. The entire conversation is recorded through an audio recorder, and it's then sent back to our head office in Australia, which is where the test is examined or assessed. So these are one key differences in as compared to any general English examination to OET. Writing and speaking varies as per the profession, while reading and listening remains same for all the 12 professions. What largely is required in OET is, as you could see, to elicit and deal with sensitive topics, and these are something definitely very common practice for all of you people coming from the same background. But what we're trying to help is translate the communication or your technical languages into a lay language for a normal people. So that is what we try to assess. Definitely we cover something how well you are able to show empathy or maintain the relationship between yourself and the patient, while the interlocutor could be a patient, a kin of a patient, or someone like that. The candidate performs the task of a profession, as I mentioned earlier, and definitely reassuring someone who is anxious, how well you can show some empathy, or console the people, or the patient who is on the other side. So these are some of the aspects which are covered in the examination. And while you're preparing for the examination, you'll realize it is 100% related to the healthcare background, and we don't largely or not at all touch upon the general English aspect. So it's more to do with your healthcare communication English, whatever you're doing in your workplace itself. So it relates quite well with your profession, and that makes OET as one of the unique tests which is loved or preferred by healthcare professions while they're preparing for a language communication exams. Again, why a healthcare specific test? I think Naveen and other colleagues would have been talking about these parameters, but definitely healthcare skills shortages is one of the key factors in some of the developing nations, or developed nations rather. Aging population is putting a lot of pressure. I think these parameters have been talked, the kind of numbers, so 14, 15,000 is what Naveen mentioned in his slides, kind of required in UK. Increased consumer expectation and high cost of communication errors. This is something very, very common. I think the last point, communication error, is something very common, and that's where the developed nations or the authorities, the medical boards, they don't want to take a chance, and that's where um, this kind of test helps them. In terms of valid and reliable, the test itself is created by healthcare professionals. I mean, the experts who developed IELTS, and that's where the makers of IELTS also help develop the examination for OET. Now, you might be surprised how that happened. I'm not sure how many of you are aware. Both the test, Cambridge and OET and IELTS, are developed by an organization called Cambridge Assessment English, which is a part of University of Cambridge, and that's where the language experts which are involved into creating both the tests are same. Tim McNamara, who was the one of the initial kind of promoters or developers of files, was also involved into developing OET. We assess all the four languages skills. Continuous statistical analysis to confirm the validity and reliability of test. We keep on doing a lot of research factors along with the Cambridge English and the University of Melbourne to evaluate the validity and reliability of the examination. So definitely, as mentioned earlier, we try and cover most of the healthcare topics and scenarios. The test itself is quite secure. There's a lot of malpractice checks which keeps on happening throughout the test process, through the world-class identification technology, wherein as mentioned, while apart from the reading and listening, we have experts who kind of do those kind of evaluations in terms of assessors. These are marked by two assessors and not just one assessor who will be marking the examination. We very well secure the online portals are secured in terms of result verification. So what happens is, while when you would have taken the examination, there's a result which is published, and the access to the result verification is given to the recognizing organization or organizations who would have recognized OET, and they would have the access to your results as well. So once you get a result, the healthcare board or the organization wherein you would have applied, they have access to see your results. So that makes it pretty much secure. And in case tomorrow, if someone would want to submit a fake result or something like that, that is completely checked over here. So obviously, reducing the factors of malpractice. In terms of what are the nations, these are some of the countries or healthcare boards which accept OET. In terms of UK, as you can see by GMC and MC, both accept OET. We are also accepted by the UK AVI, apart from Australia, and ECFMG was recognized recently, and AFRA definitely in Australia, apart from Ireland. So if you would want to have a look to the complete list, you can definitely visit OET website and see the list of recognizing organizations. In terms of what are the modes that are available for testing or taking the test, while we are available in about 46 countries through 176 test venues, OET is available through paper-based, computer-based, and OET at home. Now, what is OET at home is basically, you can take the test from your home itself, depending the technical specification requirements which would have to be met as per our norms. The computer-based test has, again, we have test venues wherein one can go and take the examination, and then paper-based assessment, we have venues all across the country. To give a quick overview, India alone would have about 24 test venues wherein one can go and take the examination. Now, moving further, there's something which we were talking about, LRWS. Now, what's in the test? So there's a listening examination, a listening test, which is covered in three parts. As you can see, Part A, B, and C goes on for about 40 minutes, and it's largely about the consultation between healthcare professional and a patient. Similar things are again covered into Part B. If you look at the short dialogues or monologues, and you have to give answers on the basis of that. Coming on to reading, again goes on for about 60 minutes, covered in three parts of Part A, B, and C. And these are again, as you can see, I'm not going to touch upon the the samples, which you can definitely look from or go through our OET website, and you'll be able to see what kind of questions or sample papers are there. So all of this is available on the website itself. In terms of writing, as I mentioned, it's a very much profession specific. So for the doctors, the questions will be very much related to your profession itself. The situation will be given, and you will have to write a case note or a referral letter to a patient, or probably to your colleague or someone like that. Again, the timing is for about 40 minutes, and that's how it goes, followed by speaking, which is done in a completely different manner. It's a more of a role play kind of a thing, goes on for about 20 minutes. So you have a interlocutor opposite to you sitting. You'll be given a situation, and that's where you will be acting as a doctor or a nurse or whatever profession that you would have chosen, and you perform the role play. So the entire conversation is recorded, and it's being evaluated by two assessors back in Australia. How is OET scored in terms of, while we also have parameters of band, these are basically 6 level bands starting from E to A level. We also do give numeric scores, and these scores or bands are also correlated to IELTS score. So in case someone would have already taken previously IELTS in past, or would want to see how they fit in with the IELTS score, they can definitely do a correlation. But in terms of how numeric scores happen, helps you is say in one of your attempts you are short behind, say by few marks, you can actually see how much more effort you would want to put in. Say for example, you would have got listening, writing, and speaking, you would have got 350 or 440 as a B band, but in speaking, or in one of the skills you have got C plus, how much more effort you would need to put in. So that's where these numeric scores will help. There's no overall score that is given, but individual scores are being given. And for UK GMC, I suppose all four, for the doctors, it's all 4B which are required as a recognition. In terms of result verification, this is something which I was speaking earlier. So the recognizing organizations get the access to this particular section or portal from the OET, and they have an access to the result verification, wherein they can go through and view your page over there, your results in case of needed. How do candidates prepare for OET? So we do have a preparation portal. There are authorized premium providers or preparation partners all across the country who help you prepare for the examination. But even if you would not want to go through the preparation providers, there are a lot of enough materials, a lot of materials which are given on the website itself. You can and go through, access through that. There are sample tests available. There are test taking tips. So we also have a free to start for success package, wherein you can subscribe to that, and this comes absolutely free of cost. You don't have to pay anything. But apart from that, if you would want to get into more higher courses, there are paid packages as well, which you can definitely go through and subscribe for it. um, Going further, there's some of the short survey. Obviously we keep on doing a lot of surveys, and this gives a very clear understanding how the healthcare professionals, or even the recognizing organizations, the medical boards, how they perceive OET as in terms of the examination itself. So we did some of the survey, and these are some of the parameters which were picked up. And if you look at the percentage, or the percentage of agreement, the employee or colleagues who have taken OET in past, and they felt that using it helped you in using English effectively in the workplace. I mean, almost 93% people said they agree to it. Communicating well with their colleagues, understand well what they are told by their colleagues. So if you look at lot to do with your healthcare specific terminologies, we don't really get into the technical aspects of your healthcare domain, but mostly onto the English communication part of it. Another survey which helped us understand how candidates were preparing for the OET and what they felt about it. So, if you look at most of the parameters, candidates agree that they strongly agree that OET helped them preparing. For the examination in terms of communicating effectively with patients and carer, writing in English in my chosen profession, reading. So I think it has been one of the preferred examinations by the healthcare professions for a simple reason that the content of the exam itself is very much familiar, or the topics are very much familiar to you, which helps you prepare for the examination very well. um, Few testimonials. These are some from the candidates. Obviously, there are hundreds and thousands which are there on the website, but just to pick up one from doctor from Iran. He says, I recommend OET to other health professions because its format really is related to skills that we need to cope with our professions. And I'm sure while when you're preparing for the examination, you can correlate how well the test is designed and fits in for the purpose. Some of the experts, what they say, definitely as mentioned earlier, one of the experts from Imperial College London says the test materials have been produced to an extremely high standard, are authentic and valid and highly relevant to day-to-day practice. So obviously all the healthcare providers or regulators who accept the examination, we share a complete understanding of how the testing is done, how we help the candidates in preparing for the examination, and on the basis of that they accept OET as a recognized organization examination. I'm not sure if we have time, but probably I would run a small video. I think I'll have to mute myself.
My name is Mulo Siwila. I'm a Zambian registered nurse, midwife, as well as a midwifery. I'm married to a mother of three boys. At the moment, I'm living in Brampton, England. A friend of mine who told me about OET, she emphasized that one, it's a requirement by NMC now, and she emphasized the fact that OET is specific to like nursing, pharmacist, or whoever is doing specific to a certain profession. I knew this would fit. I mean, the language, the aspects, whatever was involved in it, it would really go with me. I would be very comfortable. It's so professional. It was very conducive for me. I put in every effort. I went online to check for the material, and I gave myself time to study, practice, and there I was, I got it. And I must mention that it was just the first attempt, and I got all the B. I celebrated. That I was very happy because I knew now I had to start my registration, because that was the only thing that was, delaying me or maybe stopping me from proceeding to start. I was very excited. It has given me the assurance that I'm going to pass. And besides that, it has also given me the confidence that here I am, I'll be acceptable, I'll be able to communicate. And, communication is very important, especially working with nursing profession. He's a patient, you can't communicate, of course, you can't reach out. If you can't write, if you can't listen, if you can't read, you can't perform. I think that has given me the confidence that eventually I'll be able to fit in. I would recommend OET to health professionals, especially nurses, like those who are struggling with other types of, tests. They should go for OET. 100%, it's perfect. Having had that experience, I have no doubts and I have no reservations about it. This is it for health professionals.
Right. So that brings to the end. That's my email ID in case you would want to reach out to me for any questions later. I'll be here for a few minutes, and in case there are any questions coming in, I'll be more than happy to address. But even later, if you have any questions, feel free to write to me. Thanks a lot.
Thank you, sir. And there are a few questions related to OET. I think if we can take them, and then rest of the questions Dr. Shashank and Dr. Naveen can answer.
Sure, I'm just trying to refer to the chats.
Yeah, so I can just take a few
Yeah.
from the chat. So one of them have asked, is a third year MBBS student, which year would be the best to do the OET? Should I take it during my fourth year or internship?
I think what's important is, and this is more profession is specific, that at what a stage you should take the test. But in terms of preparing for your communication, I think what you need to understand is what is your level of communication, and that is very important for you to understand when you're getting into the journey. It shouldn't be a situation that after completing your graduation, you're sitting for the examination, then you realize, okay, you are not yet ready for the communication, and where you are, where you need to be expected to be, there's a long journey or a long gap. So I think the earlier you start for the communication, the more better it is. But in terms of taking for the examination, I'm sure Naveen or maybe Shashank can answer that. But definitely in terms of communication, it's an ongoing process, and you need to emphasize or be your own experts in terms of language communication.
One is which is easier to do, OET or IELTS academic?
Okay, a very good question. We keep on listening this one every time. None is easy. As I mentioned, it completely depends on to your language level. If your language level is closer to what is expected, your advanced is what is required into English speaking countries. If it is closer to those advanced level, you will be able to clear the examination. What I try to cover in my presentation, and what we do from OET is, the content of the examination is more healthcare specific, which will help you prepare for the examination. So in terms of taking the examination, we both assess you at the same level. What level is required for you to perform in a healthcare environment. But in terms of preparing for the examination, OET definitely is much better, because the content or the context of the examination is set up around the healthcare domain. We don't ask you questions like talk about urbanization, or write an essay on a globalization, or things like that. Our questions are very much related or pertaining to healthcare needs, and that's where we are unique test. There's no other test, a high stake assessment, which assesses someone's language communication in a healthcare domain. So that makes us unique.
And
Thanks for that. Yeah,
maybe
yeah.
I'm surprised that Ashish hasn't said that. No, definitely OET is an easy one. Uh, but I personally think that actually, OET is relatively easy because it is definitely healthcare specific. So it's exclusively that we have seen sending discharge summaries or referral letters to other consultant asking to see your patient. So in that context, OET kind of predominantly tests that area. I was asked to describe a Mona Lisa's painting when I did my IELTS back in the time, and that still applies. Talk about environmental globalization, blah blah. However, the reason the disparity I have to say is like, IELTS is relatively much cheaper compared to OET. Sorry, Ashish.
Yeah. No,
Uh,
absolutely.
so that is important to put into the context. So how confident you are. Perhaps maybe the best way is like to do a mock exam, which shouldn't cost you at all, and maybe you can do it. If you are super confident and comfortably doing a LTS easily, then a cheaper one is better. But if you're on the borderline and then you're scoring like 7, rather than doing and wasting time on IELTS once again, go ahead and do an OET. And usually the preparation is the same because both these exams kind of looks into the 4 aspects of your English language skill.
Yes.
I think that really helps. There is one question, if we can take. Person has asked if he passes the PLAB 1 and then take OET, and if its validity expires, can they still apply for PLAB 2, or do they need to renew it?
So I'll answer this because I know this journey quite well. Unlike James registration, as I said, predominantly there are 2 ways. three ways. One is either the PLAB route, two is the membership route, MRCP, MRCS, MRKM, or any other Royal College membership. Third is the MTI route. For PLAB and MTI routes, before you even give the exam, you need to have OET or IELTS in place. So you cannot sit for PLAB 1 exam without passing OET or IELTS. So OET or IELTS has to be ready before you submit your PLAB 1 application. Once you submit, it doesn't matter. So you've done your PLAB 1 in June 2021. You got your OET ready in place now, and that's about it. You decide to do PLAB 2 in 2022 or 2023, despite the OET 2-year validity or expiry, you have no problem because it was required for PLAB 1 application. When you apply for the visa, again, you need OET or IELTS, which is within the last 2 years. At that point, you probably will need a new OET or IELTS because there is another aspect. Once you get a job and apply for visa, you need to have an OET or IELTS for the last 2 years. So time it in a way that you've done your OET in Feb 2021, you're sitting for your PLAB 1 exam in June 2021, you're sitting for PLAB 2 in December 2021, and by March 2022, all within 1 year, you're ready with just one OET exam. So you don't have to do the exam again and again.
I think that was really helpful. And there is something, do they need OET for GMC registration?
Yes, definitely. OET or IELTS, any of them.
So I think most of the questions related to OET we have taken. Anything else you want to add, sir, Dr. Naveen or Ashish, or anything else?
No, I think,
Uh,
as I said earlier, you know,
Then we can take, yeah, so
yeah, as I mentioned earlier,
yeah.
more than happy to take the questions even if it comes later. But I'm here for a few more minutes in case if there are any questions coming later. I'll be more than happy to answer. Thank you.
My point actually, just one point. I think I like OET partly because OET assesses what exactly really happens here in the UK in the clinical sphere. So it tests your communication. And so I've seen or got to hear from candidates that they've done the OET exam. And when they come to start working or practicing, nurse or doctor, most of them, they saw it exactly like what they've learned during the practice is what is implemented or really practiced here in reality as well. So partly that way I find OED better, but you have to factor in the money as well.
Right. So little bit about cost. They are asking what is the cost of taking OET, and I'll just rough estimate, rough idea if you can just tell them.
So OET fees is in into Australian currency is AUD 587, which comes out to be into Indian currency about 32, just a simple currency exchange conversion. Sorry. So that's what we cost. But as I mentioned earlier, the cost could be higher, or as Naveen mentioned, might be higher. You can definitely do some mock assessments which are available on the website. Doesn't cost you anything. But what is more important is the context of the exam which we are assessing you upon. On the other side, you might be asked questions about anything that comes under the sky, whereas we only ask you questions which are only related to the healthcare domain, and which will be very much familiar to you. So definitely, while the cost might be higher, but in terms of preparation or any other thing, it relates quite well.
Thank you. Most of the questions we took earlier also, a lot of been answered, typed in the chat box. So you can once check. Our experts have addressed your questions and queries. Few we can again take for live discussion. I think, Naveen, sir, there's a question they have asked. MEd program, is it a good way to get into UK? for subspecialty training in the field of radiology?
For me, any program as of now, the need in the UK is quite high for doctors, so the opportunity is good. Anyone who charges you money, I think they are kind of in a way that taking advantage. I do not believe that MEd program, if I'm not wrong, would cost them around again 20 lakhs per year. 3-year program is like almost 60 lakhs. While instead spare an year, work harder, clear your MRCM exam or an MRCP exam, and then or even club exam, that would cost you around £1,000, which is like 1 lakh, or maybe at the best 2 lakhs. But then if you do MRCP, it would cost you around £2,000 altogether, including your courses you attended. That is 2 lakhs rupees. And you come here to get a direct job as a registrar. And in the MEd programs, so programs like this, which charge you so much money, you're doing the same job while you pay the salary, half of your salary back to the organization. And the degree is not any, this is my personal opinion, having spoken to so many people who have done this and so unhappy doing this. Quite a lot of universities take advantage of kind of vulnerability of overseas or Indian doctors. And my preference is definitely no. If you have to pay, if it's like a free program and then we'll give you James registration and then you get to work, but maybe with a bit of less salary, fine, that's okay. But if you have to pay a fee, no, instead you prepare in India for good 1 year, get your Royal College exam out of the way, and then come directly. Don't pay anyone any money because NHS needs doctors and you come and fill into those roles.
Okay. Also, just related to that, sir, like for the last step of like in radiology, FRCR. So, if we take in some specific countries, they give you dual degrees, like they give you FRCR and MEd, but they charge you extra. So, is it worth taking that because you clear one exam, they give you two things together, or is it just go with one thing with a lesser cost?
I think Dr. Patka might be an expert in FRCR. Uh, uh, I know that to get GMC registration, which is the most important thing, you have to complete all parts of FRCR.
Right.
So I'm not sure about the
So,
dual
is it
degree
worth
side.
taking MEd with it? Yeah, because like suppose you take exams in Singapore or some other this thing centers, they give you on clearing that simultaneously you get two of them, FRCR with MEd. So, is it worth taking those or just go ahead with one thing? And it's like almost giving you the same advantage.
I believe you don't. Uh, so MIT is like a way, quite a lot of private universities kind of draw you into this. And I'm not sure. I don't think actually, particularly if they cannot give you direct GMC registration. Shashank is raising his hands. I'll
Yeah,
leave him. I think he's an expert
that's
on
a
this.
very important point because what's the objective? Why are you getting these degrees? Just to add letters, or is it some form of qualification? If you're doing FRCR is mandatory to become a consultant in UK. Okay, MEd probably is not. Okay, and that's you got to understand what's the objective. Why are you getting that degree? And that's very important. Where do you want to practice? So if you understand the objective and if you understand or you're very clear in your thought process where you want to practice, you'll be very clear. So just collecting degrees is not an idea. It is about an objective of doing that course or objective of doing that training program. I think
Yeah.
at an individual level you have to put that thought process.
Okay, sir.
Another
Thank
thing,
you
I'll
for
give you
that.
a
Yeah.
very relevant example. Sorry, Mitusha.
Yeah.
Like an MCH program, which I was mentioning earlier, it costs around £35,000. And doctors do come from India. Say you have done MS orthopedics 3 years. They think that, okay, I'll do MCH over here because MCH, is like super specialization. MCH urology, MCH, we have, cardiothoracic surgery. But then once they come over here paying so much money, they realize this MCH it's like absolutely, they hardly get like 1 or 2 operating experience per week. So in India, you probably, as an MCH, say your surgical portfolio shows you around 2,000 surgeries. Over here, you're probably hardly doing 200. So not anywhere close to equivalent to Indian MCH at all. And the same MCH, you can do an online module paying only £4,000. If it is really the title which is important for you, like I want to say that on my title, like I'm MBBS, MS, Auto, and MCH UK, you can get that MCH paying only £4,000 for online modules. You don't have to pay £35,000.
Okay, sir. So, as Dr. Shashank said, that your aim should be clear. It's not just about adding the degrees. You should be clear, like what you want to achieve at the end of it. And for being a consultant position at UK, you don't require any additional kind of degrees, fancy ones, but the ones which are really needed. That is what you actually work for. Another question is Dr. Umesh. He's a transplant nephrologist working in Mumbai, and he's done his transplant fellowship from Canada, cleared MRCP2, awaiting PACES. Is it possible, looking at the current COVID scenario, to get a direct consultant post, or will he have to do a higher specialty training?
I answered that question, but I'll repeat it on the video. Basically, to be a substantive consultant in UK, you need to be on the specialist register of GMC. They hold a special register for all the people who have completed a training program, and the GMC says now you are on a specialist register for nephrology, and then you can practice as a consultant. Okay. In Dr. Umesh's scenario, I personally feel, or rather, I'm very confident he wouldn't be he wouldn't be offered a consultant job at a substantive level in United Kingdom because he's not on a specialist register. He will have to complete certain. He firstly, you have to submit all your qualifications and experience to an institute. They will assess where you are on the training. Then they will say you have to complete this aspect. You have to go through that journey with a supervisor and then apply to GMC to be on the specialist register, and then you can work as a consultant in United Kingdom. That applies to all specialities, just not nephrology. This is where everyone is. If you are a specialist and you want to come here, you can't be a consultant directly because you're not on a specialist register. Uh,
Okay.
And then the thing I'll have to say, what very recently this happened, very recently. A doctor who has done DM gastroenterology in India and has completed MRCP, all parts, including the PACES, Umesh. And then he applied for a job, and through a different hospital, he got what it is as a locum consultant. The hospital is desperate for gastroenterologists. They have like an at least need for, I think, 4 consultants. They have one person doing the job. So they're desperate for gastroenterologists, and then they offered him a locum consultant job. And they said that, oh, we interviewed him, he can do endoscopies, we are very happy with him. And then once he came over here, GMC said, like, because he passed his GMC criteria, which is he cleared his IELTS, he cleared his MRCP, and that is what GMC needs. And then he got his references. GMC gave the registration. Hospital employed him as a locum consultant, which is not anything as what Shashank's role is or Shashank just talked about. So they can do a consultant job, but then they are just only like a filling in post as an acting consultant, not really a real consultant. However, this brings in a lot of additional responsibility. As a consultant, the onus kind of just directly falls onto you. When you take up a role as a consultant, if any of your junior makes a mistake, if a patient has had an GI bleeding post endoscopy, you didn't pick up, somebody said that discharge the patient, and particularly they had risk for DVT, they gave them Flexaid, complication happens. The whole onus comes just onto you because you are the consultant of that team without knowing the system and then the cycle of the NHS pathway, how the system works, and then how your juniors or how the patient, does he go come to an emergency department? Does he directly ring you on your phone? Without knowing the whole process, usually the patient goes to their general practitioner. From there, he will assess, and then he probably is not confident. He'll say, "Oh, just go home and take some omeprazole." So without understanding the cycle of a patient journey, it's a big responsibility for you to take straight away as a consultant. My advice is come and work as an associate specialist or like a senior registrar in a department while the onus is not directly on you. But this is pending or after your paces, not before. So once you do your paces, work as an associate specialist, 3 months, 6 months, probably have an arrangement with the interview team saying that, right, I want to know and understand the system. At the end of 6 months, you probably will have gauged me as well, how confident and how comfortable I'm doing endoscopies and making decisions. And I would know the system and how comfortable and confident I am. Then I'll take the locum consultant. You don't want to take the big responsibility over here straight away. My small piece of
So I think that is really important because when people get an opportunity for being a locum consultant, it seems really attractive that directly going as a consultant. But definitely a great practical tip I feel that you can take a 3 to 6 months of time to understand the system and then take that responsibility. Thank you for that. There's a question: do we have to pay a tuition fee like in Indian residency in foundation year, core training,
Yeah, nothing.
okay.
nothing. Over here, your expenses are like there is no fee at all. You work and then you get your salary while working. You get through your exam. So we don't take time off like preparing for your MS or MD in India as in India. While working as a doctor, junior, middle grade, or senior level, you get through your exams ideally in between. You make that time for yourself. But then the working hour maximum limit is 48 hours per week. Nobody works more than 48 hours at all over here. So there is a European Working Times Directive that no doctor should be overworked. They've seen the and then put systems in place that is in fact counterproductive for the department.
There's a question related to stipend as well. What is the current stipend for MTI?
Shashank is the master expert.
Well, it's nothing. It's purely the hospital decides what's your clinical experience. So if you're applying to me, I'll take your experience into consideration. I take your qualification into consideration, and you're just put on the equivalent pay at that level. So if I judge as a department that you are at a junior registrar level, then there is a set NHS pay scales, and I'll say this is what I'll let the HR know. I want this doctor to be on this pay scale, and that's how pay scales are decided. There is no other alternative rule. Everybody is on the same page, overseas or UK graduate. Straightforward.
There's a question that if somebody has doing PLAB now and if it becomes void if not completed by 2020 as the UK MLE comes, so the status when the UK MLE comes in for PLAB.
We, in fact, actually, when we did interviews last time, we invited the head of overseas registration from GMC. And I approached, although a bit late, probably for the next talks. What I can do is get one of the GMC representatives to come and answer these questions. And so whatever I'm giving is kind of a speculative answer. I'm reasonably or close to certain that it will not become void. Whatever is in the transition will continue. And it happened actually, if you are doing FRCEM or MRCEM, when I was doing, it was changed into FRCEM by the Royal College of Emergency Medicine. And they didn't say that, oh, MRCEM is not valid or you pass part of MRCEM, it will become invalid. They give you always enough time for the transition. So maybe within the next 1.5 years or 2 years, you have to clear your OSCE exam of the PLAB or PLAB 2. So I'm sure that will be the case, and but a more definite answer perhaps if there was a next conference and we can invite directly the GMC person as well.
Sure. So I think we have taken most of the questions for today. So Dr. Shashank, yeah, you can just
One point. I mean,
yeah,
there are lots of questions around CV, and that's
yeah,
very important when you're
yeah,
applying for a job. I thought I should answer that.
yeah.
So any CV should be in a very standard format. Okay. And GMC has an excellent guidance on how to write a CV. Okay. However, how to build a CV is more than qualification. So you should be quite clear in what is your skill level first, apart from your qualification. You got to be very explicit. You got to really explain the roles that you have done in particular job. Was it just history taking? Was it operative? Was it communication? Was it research? It is very important for any hospital to know that level. That's second. Third, if you have not done an audit, please do not lie. There is no scope because I can tell you, I will conduct an interview. When I conduct interviews, you ask questions, you know that this is a made up thing. There is nothing, there is no impact of it. So never write anything on the CV that you have not done because they have asked for it. Might as well do it and then do it. Do a 5 patient audit, do a 10 patient audit. At least you'll be confident when you answer. So please do not do that. Please do not make up posters. Please do not do anything like that. But it is important aspect. So to summarize, look at GMC, how to write a right CV. It is not about glorification, it's about reality because it's a fair thing that will happen to the people who are employing and you will come at a right level where you should be and then you can only progress from there. So it's all about being very clear of what you are. Don't try to judge yourself because people who are employing will decide what is right for you. Because I can tell you from my experiences, if anything in this country I've seen is fairness. I had prejudices, but I can tell you there is fairness if you are doing the right things right.
I like actually what he said, and absolutely that's true. In a way that the systems are in place to be fair and then treat everyone equally. There might be occasional odd cheeky ones, particularly mostly the HR teams, trying to undermine your Indian experience and then not giving enough validity for it and then put you on a lower pay scale. Bravely so. But then usually the consultants stand up to it. They identify you. Sometimes we I've done the distinction earlier in my talk. Say with 4 years experience, we treat ourselves as consultants. MBBS, 1 year house surgery, 3 years MS, and then you're an orthopedic consultant or a surgical consultant. Over here, it has to be 10 years. So you can't say that I need to get paid as a consultant. No. So they have, and most clinicians who are in the interview, they kind of rightly identify what would be a most matched one. Coming to the CV, what I can do is you can distribute amongst to the candidates later. I have prepared a template CV because we do have doctors come and register with us, which kind of very easy. You just fill in your details there. At least it gives you an indication of what an interview panel is looking for, particularly when you're applying for a training job, and how not to lie about them. And then what are the factors you can add? What are somebody says that I give a declaration or like nothing wrong. My husband or my wife is this, and then I live in this address. Probably a lot of those details are not required. There's no declaration requirement. We don't need to know in an interview like your kids go to which year, which school. So, but so I'll put them all in a template, kind of pretty straightforward. Happy to distribute it. So it makes it easier for them when they're structuring any jobs wherever they are applying. And the GMC or there are Royal Colleges and even BMJ, if I'm not wrong, have got a template CV with them. So they can look up on there.
So that will be, I think, great to have that template to prepare a CV. And people are asking for email IDs for both of you to send their queries further. And there is on the screen, we have also given a contact email ID and WhatsApp for Med Virtuals because there are going to be programs coming up on similar lines. So please do post your feedbacks because that will help us to design the future events and programs and to get experts, as Dr. Naveen said, that we can get actual experts from GMC to answer these queries. There is a question by Dr. Megha. If we have completed FRCR 2A, what are we eligible for? I think which posts are we eligible for?
I'm afraid actually not eligible for anything, Mega, because the rule is like you have to complete all the parts of the Royal College exam. So you need to complete the final part 3 as well. Same applies with MRCP. Part 1 and 2 will not do it. You should finish the paces. In the current COVID environment, exams are being particularly cancelled, and you have to be. I was in one of the webinars with the RCS, and then they did implicitly say that a bit of preference would be given to the UK trainees in allocating the positions, understandably. So when your time comes to sit for the clinical exam, you might somewhere be back in the queue. But GMC have made a lot of big changes recently. So when I came, it was only club exam and then you get James registration. Over the last few years, they said like if you do any of the membership exams, any of them, MRCP, MRCOG, MRChem, MRCS, FRCR, then you can get James registration. Just recently, 1.5 months ago, they said like if you have done USMLE, you can get James registration. So back in the time, I didn't have to do a lab exam because I've already done USMLE. Now they added into it because I think these countries are kind of competing to get in kind of overseas, good overseas or Indian talent. Uh, Given to the need, I'm not sure. Maybe when the James expert comes, we can ask about like say clearing two parts. Will you give GMC registration? Would they consider giving? As of now, I know you cannot. So just doing two parts will not get you anywhere
Yeah.
unless you finish the final part. But is GMC going to mend its given to the COVID pandemic? Will change its registration requirements? We don't know. We can ask them.
Dr. Megha has reframed it. So after clearing FRCR Part 2A, which ST post will she be eligible for? ST eligibility. So is that their ST eligibility will be there after FRCR 2A? Or still we have to complete all the parts?
Again, you don't get James registration. Without James registration, you cannot work at all. So it doesn't matter, ST1, ST6. Usually, when any radiologist from India who come to work in the UK, whoever we engage with or seen, actually as friends have come as well. And what they do is all parts of FRC are clear. Either they take up a locum consultant job, like I gave the example of a gastroenterologist, at least the radiology is not that bad compared to because your clinical interaction is not so high directly and you're reporting, you understand the systems, you can probably learn quickly and they're guided well by the radiologist over here. So you can take a locum consultant post or that specialty associate specialist doctor after 3 to 6 months, take up a locum consultant job. And that would be like an equivalent. If you have to choose an equivalent, it would be like an ST4, ST5, or maybe even ST6. You don't have to do like an ST1 equivalent. But without passing the final part, no job you would get.
So any other specific question, Dr. Shashank, Dr. Naveen, you would like to address if you have seen from the chat box?
I think people are talking about clinical attachment and exam criteria, but clinical attachment, that concept has gone altogether. You don't get clinical attachment, and I don't think so. I think clinical attachment is basically you're underselling yourself. Please don't do that. Okay, I think you should really ask for a junior level job rather than a clinical attachment. So if you think you want to understand the system, work as a junior SHO or something like that, but don't take up a clinical attachment because all these posts are very well supervised. So you're not taking independent decision making. So that's first. Somebody was asking about MRCP passing criteria. I think Royal College website is where you should be looking at because they explain that very well for each and every college has a different criteria. It's an exam. You have to sit an exam and you have to pass as per the criteria. So that's second. There's a good suggestion from someone about having a specific webinar about what should be post MBBS, what should be post MD, what should be post MD with the foreign exam. So I think we can help if Dr. Parker and his team would like to work on that. So that's that. And then there are more of eligibility questions, which I will kind of defer to Naveen. I think these are the questions. It's quite difficult to answer directly like that. I think so. Your emails would be appreciated.
So I believe Dr. Naveen, we can have a closing remark, and then Dr. Shashank, and then Patkar sir can give his closing remark, and we can declare the next session, and the topics from your feedbacks we'll definitely take in. Yeah, Dr. Naveen.
I didn't have a closing remark. And I mean, it's only like as I shared the experience. I don't think there is a right or wrong path. Just nothing wrong in trying things. And don't feel disheartened if you don't succeed or get in through and then Do not, yes, it's good, but if you come with less expectations that I'll get into a training, I'll become a consultant, it will be easier. You want to live through the journey, right? I want to see how the UK system works. I want to experience like how it is different to India. And maybe if you choose to go back for any reason, and then you know at least you pick up the right things or the good things from here and incorporate into your everyday practice, like current best evidence or reading about research and the current articles and doing right things. And that is one thing I think I have seen and become to be a bit of a good doctor. I wouldn't say, all my friends say whoever in India, they're also excellent doctors. But maybe, yeah. So try it and plan it, and then don't hesitate. We didn't have the guidance. That is the reason why I started this. Without that mentoring or guidance, you could be easily lost in this space, and then you will invest a lot of time and money into it, and just do that a little bit smartly. So the choice to come is right, but then when you make the choice, look into the overall consequences of it. If you don't get into, even step into the UK, you worked hard and then they shut the doors suddenly because they had enough doctors. So anticipate it a little bit. Feel free to reach out to us or at least attend these conferences, webinars. We will not be dishonest or misleading you, at least from our observations over here. And I immensely love working with Shashank or knowing him. He works like true to the heart and a very straight person. So yeah, that's it.
I enjoy a bit of flattering, so thank you, Naveen. So besides the point, what I would say is be honest, be truthful, focus, read the regulation, do not undersell or oversell yourself, make a right assessment before you apply. There is a lot of medium, and I'll be honest, I try my best to answer my emails, to do email to myself on a week. I would try and answer the questions the best possible way, but take informed decisions. Do not get misguided by opportunities like golden handshakes, because in this world nothing comes free at a cost. There is nothing, there is no freebies, especially when somebody's telling you, oh, we'll sort this out. Nobody is going to do that for you. Once you are here, you are on your own. So make those informed decisions. So that's why talk, get that information, and that's all I would say. And thank you, Dr. Patkar. Thank you, Nitusha, Amit, Gauri, and Medi Virtuals for this bringing this webinar together. So I really appreciate and enjoyed this morning. Thank you.
One last point I'll say, it happened to me, and then a lot of doctors when they come from overseas, you kind of fall into the 3B criteria. And what Shashank said, focus is really important. The 3Bs are beer, biryani, and Bollywood. Because I've come into the UK now, I think you should stay focused actually, because passing your exam or progressing in your career, as I said, journey, it doesn't stop once you enter or come into the UK. Just pursuing. There is so much you could achieve and do. And thank you, really, Dr. Parker and Mary Virtuals. I think this idea as such is very innovative and very helpful. I can only imagine, like, say, back in the time, and a lot of candidates who I interact with, if I had this guidance beforehand, and this medium is really helpful. Thanks, Amit, as well, and Matisha for coordinating.
Thank you. Patka sir, your remark, and then we can close this session.
So taking beer, Bollywood, and biryani forward, this was a great first day, first show. I think a lot of people got help. I think we continuously had about 100 people. Now we have about 43. We'll take feedback from all these guys and see how we can do better next time. Any inputs from Naveen and Shashank are always welcome, and we'll work towards getting this very, very successful. Thank you. And thank you, Mitusha, Gauri, and Amit, as always.
Thank you, guys.
So thank you, everyone. Do stay in touch with, these are our WhatsApp and email IDs, and you can definitely send us feedbacks and the amount of like kind of details you need for the next sessions. We can plan it like maybe every month or so as per the availability of the experts, and they will definitely reach you well in time with the relevant details. So thank you once again. for your time and attention. I think, Amit sir, we can call off the meeting for